All right, everyone, I'm going to get us started. My name is Lindsay Miller. I am a papillary thyroid cancer survivor from Albany, New York. This is my first in-person conference, so I'm happy to be here and see you all in person. And I'm going to introduce today's speaker, who is Dr. Konda. Dr. Konda is a medical oncologist at the Ohio State University College of Medicine in Columbus, Ohio, specializing in thyroid, adrenocortical, and neuroendocrine tumors. As a member of the Translational Therapeutics Program at the OSU CCC, Dr. Konda focuses her research on providing better treatment options to patients with endocrine-related cancers through clinical trials. She is the study chair of 2 multi-center investigator-initiated trials for thyroid cancer in patients, sponsored by the National Cancer Institute's Cancer Therapy Evaluation Program, one of which she designed from its inception. So I'm going to turn it over to Dr. Konda. We will have time for questions, and we'll just make sure to use the microphone when we get to that point, since she's joining us via Zoom, and we might have some Zoom participants as well. All right. Thank you, Dr. Konda.
Thank you. Thank you so much, Lindsay, for the kind introduction. Good afternoon, everyone. And thank you all for coming. Sorry I couldn't be there in person. It's truly an honor to be talking to you all today. And I'd like to thank the program planning committee for this invitation. We'll be discussing about the systemic therapies in advanced radioactive iodine refractory differentiated thyroid cancer today. Here are my disclosures. So I'll start with some fundamentals and definitions within thyroid cancer, talk about some basics in drug development and some terminology that's used in clinical trials. And then we'll talk about the factors that are involved in our decision in starting patients on systemic therapy, regarding when to start, and once we decide to start, what treatment options are available and what do we start them with. We talk briefly about redifferentiation therapy and its current status, and then we'll go over a few emerging clinical trials, and then we'll end with a few take-home points. So as you can see here, the incidence of thyroid cancer has more than doubled in the past 3 decades from the year 1992 to 2020, with over 40,000 new cases estimated in 2023. Compared to the other cancers, thyroid cancer is relatively rare, and it accounts for about 2% of all new cancer cases, and about 0.3% of all cancer deaths. So this is a little cartoon about of our thyroid gland. So if you cut open the thyroid gland, you'll see these little follicles like this, these circular things. And the cells that line these follicles are called follicular cells. And outside of the follicular cells, these blue circles are called parafollicular cells or C cells. So cancer can arise either from dysregulated growth of these follicular cells or dysregulated growth of parafollicular cells. If cancer arises from these parafollicular or C cells, then that's called medullary thyroid cancer. And if it's coming from these follicular cells, then it's either differentiated thyroid cancer or anaplastic thyroid cancer. Anaplastic thyroid cancer is a very aggressive thyroid cancer, which we will not be discussing today. Our focus is on differentiated thyroid cancer. So within differentiated thyroid cancer, there are several types. There's papillary, follicular, oncocytic carcinoma. It used to be called Hürthle cell carcinoma. Now the name has changed to oncocytic carcinoma. And then poorly differentiated thyroid cancer. Most clinical trials have studied they've kind of lumped all of these cancers into one category as differentiated thyroid cancer, and all of these patients are enrolled in most clinical trials for differentiated thyroid cancer. Now, what is metastatic thyroid cancer? So in this little schema here, here's the thyroid gland, right? And this black is tumor. And we see, so the tumor starts within the thyroid gland and spread outside of the thyroid gland. It went to lymph nodes, it went to lungs. These are the lungs. And then it went to bone here. So this is metastatic thyroid cancer, cancer that has spread out of where it started from to a distant location like lungs, bones. These tumors like to go to the lymph nodes, like to go to lungs, like to go to bones, sometimes can go to the brain. So what is radioactive iodine therapy? What is the mechanism behind it? So our thyroid gland and also thyroid cancer usually is very hungry for iodine. And that's because iodine is taken up by the thyroid gland cells, and those thyroid cells make thyroid hormone and secrete thyroid hormone. So that's why it takes up the iodine. So based on that, scientists developed radioactive iodine. So now this is a radioactive form of iodine, and the thyroid gland doesn't know whether it thinks it's iodine, so it picks it up. And that goes into the cells of the thyroid gland, and radioactivity is released, and that emits beta radiation to try to kill the cells, trying to kill the tumor. So typically, most patients with differentiated thyroid cancer, whether it's early stage, whether it's locally advanced, whether it has spread out, the first typical management strategy is surgery to get rid of the thyroid gland and the tumor in the neck. So that's usually the first step. For example, this patient here, disease is just localized to the thyroid and the lymph nodes here, and all of that is removed. And then patient gets radioactive iodine treatment, either to remove any remnant thyroid left over or to treat any microscopic disease that may have spread that you cannot see on the scan. So this is the usual treatment strategy. And then patients are, sent home on levothyroxine, or Synthroid, in order to keep their TSH well suppressed and keep the cancer controlled. Now, this patient, 6 years after the surgery and radioactive iodine therapy, now develops tumors in the lung. So now he has distant metastatic disease because disease has spread out of where it started from now to the lungs, right? So about 10% of patients with differentiated thyroid cancer would develop metastatic disease in the first 10 years after the operation. So then the patient gets radioactive iodine treatment, the tumors shrink. However, 6 months after the radioactive iodine treatment, now the tumors are again starting to grow. Now that's a problem because that's very close to after completing radioactive iodine treatment. And now this is called radioactive iodine refractory disease. So radioactive iodine refractory means it's now resistant. It's no longer hungry for radioactive iodine. So we have to think about what next. So now where do we go from here? So now patient comes to me with disease that has spread out of where it started from. Do we start them right away on treatment? Do we wait and watch? Where do we go? And there are several factors that we have to take into consideration, and we can broadly divide them into patient-related factors and tumor-related factors. So what are the patient-related factors? So number one is goals of care. So Once the tumor becomes radioactive, iodine refractory, has spread from out of where it started from and is refractory to radioactive iodine, you can no longer get rid of it. Your goal is, how can I control it? How can I preserve my patient's quality of life? And how can I prolong survival? So those would be my goals of treatment. And many times, active surveillance or waiting and watching is our initial strategy, because the treatment options we have, though several of them are very effective, they have a lot of side effects. And the benefit lasts only for so long. So you don't want to use up your options too quickly either. And you don't want to ruin a patient's quality of life either. So many times, active surveillance is the initial treatment strategy. It's important to look into my patient's performance status and age, because an elderly, frail patient, I would be worried about how he or she would tolerate systemic therapy that I would administer. Occupation, a guitarist who uses his hands a lot, would be worried with if he develop hand-foot syndrome and no longer be able to play his guitar. So that's something things that we have to prioritize. Medical history is important. Is my patient able to swallow? Is my patient able to absorb the pills? Does my patient have high blood pressure, and is it well controlled? Because many times these medications will cause high blood pressure, and you want the blood pressure well controlled. Is there any history of blood clots? Is there any history of heart failure? What medications is my patient on? Could they result in any interactions with the medications I'm giving? How is my patient's social support system and family support system? Because there will be side effects from the medications, and I want to make sure that there's enough support socially and within the family to care for the patient, because it takes a village. So then there are some tumor-related factors that we take into consideration. For example, if the tumor is close to the airway, then I want to treat. I'm not going to wait, because I know that if it's pressing on the airway, the next thing, my patient will have trouble breathing, or there could be bleeding. So I don't want to take a risk. If patient comes in for his first visit and has a lot of tumor burden already, then I don't want to wait too long, because I don't want to miss the window either. But if there's a small tumor burden or moderate tumor burden, I want to wait and watch and see how the pace of the tumor growth is. Is the pace of tumor growth rapid, or like I tell them, okay, come back in 3 months' time. In 3 months' time, if it's already grown significantly, then there's no point waiting. But if it's hardly grown, things are pretty stable, tiny millimeter change, then in locations that are not danger locations, then I would wait and watch. Is my patient symptomatic? Symptoms developing hoarseness of voice because of the tumor is pressing on a nerve or a cord, or having cough, trouble breathing from the tumor. Sometimes we also take thyroglobulin. Thyroglobulin is just a number. It is this protein that these cancers produce that you can measure in the blood, and we can use it in combination with scans to tell us how the tumor is doing. So it should always be used in conjunction with scans, not just by itself, because ultimately you're treating your patient. You won't treat a number. So it's kind of everything together you want to take into consideration. So while waiting to start systemic therapy, right now, the small tumor burden, it's not in danger locations, patient feels well, no symptoms, you're waiting and watching. Now is the time to get the blood pressure under control. Make sure you get a next generation sequencing. What is next generation sequencing? So in patients who had prior surgery, right, pretty much all of them would have prior surgery. Or if there was a more recent biopsy from the metastatic side, that tumor is sent to a company where they sequence the tumor and analyze the tumor to see are there any abnormalities within the tumor that we could have medications to target. And that will give us important information, because if there's some actionable alteration that comes up, then great. That means, maybe you are opening up another treatment option here. And also, it will help us understand the biology of the tumor, because there are some alterations that may predict a more aggressive course of the tumor. So it would be important to know. So most insurances cover next generation sequencing. It's either done through Tempus or Foundation Medicine or internally. Many institutions do it internally as well within their institution. Now, this is an example of a patient where here you see there's a small tumor here, and then a patient was we waited and watched, and in a span of 11 years, this is how much it grew. Did we lose anything by waiting? Not really, because patient still feels well. Yes, there's some growth of tumor, which is expected. But now I see that, yes, it's here. Maybe I want to do some radiation to this so that I can get some control before it kind of presses on the airway. But you've given the patient 11 years of no side effects from any treatment. So that's wonderful. So that's the beauty of active surveillance if it can be pursued. Just a little bit about drug development. So to understand how a medication comes out to the market, right? So these medications are very rigorously tested in multiple phases. So number one, before a medication is studied in humans, it's studied in animals and mice, in vitro, in petri dishes, to figure out, what's happening. Is there some signal somewhere we think could be efficacious? And then when we are seeing signals, then it goes on to the clinical phase. And that would be the initial phase 1 study. And there what happens is a small study, and your questions are, is this drug safe and in humans? And what is the dose that I have to give my patient for us to give it safely, but also have some benefits? So that is a phase 1 study. It takes several months to happen. And most of these studies move on to the next phase, which is phase 2. Now, phase 2 is a little more advanced. Now you want to understand, okay, now I know that from early data, I know that this drug is safe. I know what dose to give my patient. Now, let me study in a larger population. Now I enroll a few hundred patients to see. My questions now are, is it effective? And I also want to know, are there any side effects that I didn't understand in phase 1 that I'm seeing in this larger group? So that's a phase 2 study. It takes several months to years to complete. Rare disease groups like thyroid cancer, it could take longer because there are fewer patients. So then a third of these studies go on to the next phase. Now, if you're going to phase 3, that means clearly the drug is showing promise. So now you want to know, is this drug better than what I already have for this cancer? So I'm comparing it with the standard of care. That is a phase 3 study. So now I understand more about the efficacy, more about the safety, and if I see that the drug is superior, then it goes on to FDA approval. So it takes a lot of time and years for FDA approval to happen. So there are several times that we treat patients already based on the data we have from these studies, even though the drug is not FDA approved, because, you know, if they're showing some activity and we see the activity is promising, then, you know, sometimes we treat patients off label. Off label means outside of the FDA approval, because how long are we going to wait for FDA approval for these rare tumors? So there are several things that come up in clinical trials. The patient had a complete response, had a partial response, had stable disease. What does that mean? So these are the lungs, and this black is tumor, for example. Complete response means everything goes away. This is very unusual to happen typically. You know, we are yet to find a medication in differentiated thyroid cancer where we see complete responses in this fashion. This is more common. Partial response means there's at least a 30% reduction in tumor size. This is many clinical trials, drugs that we test, which we say are efficacious, show partial responses. Stable disease means there's not much difference. That means if it's a 20% reduction, for example, it's considered stable disease. If there's a 10% increase, for example, it's considered stable disease. So it's not grown that much or not shrunk that much. That is stable disease. Progressive disease is now there's at least a 20% increase in size of tumor, or any new lesions that come up is progressive disease. This means that it's clearly not working. So for example, a patient cancer is growing, you start them on a medication and they have stable disease now. That's still a victory, because at least the tumor has slowed down. So that is, you know, tumor that was growing and now stable, that is a good sign. So there are also several things that clinical trials and papers talk about, like what is progression-free survival. It's also called PFS, progression-free survival. Progression-free survival means how long from the start of study treatment do patients live without the cancer growing. That means the cancer is not grow. How long has it stayed either stable or responding for, like, but not having progressive disease. That is progression-free survival. Overall survival means how long from the start of study treatment did my patient live for. That is the overall survival. Objective response rate means what proportion of my patients have at least a 30% shrinkage of tumor on this treatment. That's called objective response. So these are the things that we usually look for in clinical trials. Typically progression-free survival and objective response rate. If those are high, then we like it. So what are our targets? What do we need to target for when we give treatment? So this is an example of a normal cell. This is a normal cell in our body. It has these projections called receptors. These receptors receive messages from these messengers, and these receive these, you know, this is a normal cell cycle. They receive messages, they go through certain signaling pathways, and the cell grows normally. However, sometimes dysregulated messages come to these receptors, or the signaling pathways are dysregulated. And then now there's abnormal cell growth and proliferation, and now you have a cancerous cell. So now this is a cancerous cell, right? Like abnormal signaling somewhere. So what we try to do is develop drugs that block either these receptors that are causing this cell to grow, or block these signaling pathways in between that are causing these cells to grow. So then there are several of these treatments. That's the mechanism basically. How do I target these so that I slow down this process and I either stun this tumor or I kill the tumor? So that's kind of the thought process behind it. So in several studies, several medications were tested and, went through all these clinical trials, phase 1, phase 2, phase 3. And these are some of the promising therapies. The ones with this red check mark tell us that these are FDA approved options. So sorafenib was tested in a clinical trial and was compared to a sugar pill, because way back then there was no standard of care for thyroid cancer that had spread. So you compare it with a sugar pill. And the responses, so out of 100 patients, 12 patients had tumor shrinkage. Response rate was 12% with sorafenib. And the progression-free survival, that means how long was my patient from the start of study treatment, how long was my patient without disease progression, how many months for, and that was 10.8 months. Then subsequently lenvatinib came up, and lenvatinib was compared to a sugar pill, and responses was 65%. So that means out of 100 patients on the study, 65 patients had tumor shrinkage, and the tumor shrinkage was at least 30% tumor shrinkage. And the progression-free survival was 1.5 years. That doesn't mean that they were living for 1.5 years. It means that they did not have progression, right? Like that the progression-free survival was 18 months. And cabozantinib is a newer medication that came up in patients who progressed on either of these medications. This is an option, and it was studied, and it showed in patients who progressed on sorafenib, lenvatinib, or both, 11% response rate. So 11% of patients had tumor shrinkage with a progression-free survival of 11 months. Our group conducted a clinical trial, which was a phase 2 study, so medium study, right? Compared this medication dabrafenib versus dabrafenib with trametinib. This is in patients with BRAF mutated tumors. Now, the reason I said we should do next generation sequencing, right? Like sequence the tumor to figure out actionable mutations, is to find things like this. If there's a BRAF mutation, then that BRAF mutation is what's making the tumor grow. So then you target that BRAF mutation and you block it to try to kill the tumor. So the dabrafenib blocks that BRAF. And this trametinib blocks another signaling pathway below it. So these were compared head to head to see which one's better. And there was not much difference between the two medications, the two regimens, at least statistically. So the combination is FDA approved currently, 30% response rate with 15 months of progression-free survival. But many times we also start patients on just dabrafenib because, the side effect profile is a little bit better with dabrafenib compared to dabrafenib with trametinib. Vemurafenib is a cousin of dabrafenib. Again, responses are comparable. This is in patients who didn't have any prior lenvatinib or sorafenib. The responses seem higher compared to those who had prior lenvatinib or sorafenib. None of these are FDA approved, and this was an early stage study that was done it was also phase 2, sorafenib with everolimus, and this was only in HER2 cell cancer patients and now called oncocytic carcinoma patients. And in this combination showed efficacy in 18% of patients with a median PFS of over 2 years. So that is quite encouraging. And many times we use it off-label, which means not FDA approved, but we're using it because it showed some efficacy. And, if a patient benefits, we want them to be able to use it. There was another clinical trial where patients, there were 2 cohorts of patients. One group received both lenvatinib and pembrolizumab. Pembrolizumab is also called Keytruda that we hear on TV. It's immunotherapy. So they got the 2 upfront, and there was another group of patients who were already on lenvatinib and they were progressing, and then you added the Keytruda when they were progressing. So in the group that you added the Keytruda when they were progressing on lenvatinib, after you added the Keytruda, 15% of patients had tumor shrinkage, and the progression-free survival was about a year. So that's pretty good. So sometimes we use this also as off-label. Dabrafenib plus lecpatinib, this was very early stage study, phase 1. And Dr. Sherman's group did it, and they're working on next steps for a larger study, to a phase 2 study. But this combination showed responses of 58% with 18-month progression-free survival. It's hard to get insurance approval for these because it was so early stage we're basing on, so we need more data because it's a very small number of patients who were tested. So before we can use it in clinical practice, we'll need some more data. We had led a clinical trial where cabozantinib was combined with 2 immunotherapy medications, nivolumab and ipilimumab. And this study was sponsored by the NCI and ITOG, the International Thyroid Oncology Group. Unfortunately, the combination didn't show, 18% response rate is not that much, because just cabo alone has response rates of about 11% already. So 18%, you're not achieving that much for a combination that is toxic. So it didn't move on to the next phase because we didn't think that we are seeing a promising signal here. Then, as I talked again about next generation sequencing, sometimes patients have a RET fusion PTC, papillary thyroid cancer that is RET fusion positive, or an NTRK fusion thyroid cancer. These are very rare, but if they have these, then it opens up other treatment options which are quite effective. These are targeted agents. So that's the reason why we like to do this sequencing. Most institutions do them now. This is an example of a patient with response to lenvatinib. This is the lung, this is the left lung, right lung. These are the great vessels in the chest. And this white is all tumor. These white round ones are tumor. And this is November 2015. Patient started lenvatinib. By 3 months' time, there's so much shrinkage of tumor. So it's amazing. The responses we see with lenvatinib are clearly great. See, because 65% of patients will have tumor shrinkage, thyroglobulin goes way down, right? So that's great. This is a patient on vemurafenib, which is not FDA approved, but it's a BRAF inhibitor. Again, the tumor, this is the neck. This is the airway here. That's a big tumor in the neck, and it shrunk to that. So that's wonderful. The airway is nice and coming back to the center now. It's important to remember that with BRAF inhibitors like vemurafenib or dabrafenib, the thyroglobulin will go up, but it's not of concern. Even if it goes up, you shouldn't worry about that. This is more important. This is going up. There's a mechanism for it. It does it because it redifferentiates the tumor is what we think, but it can go up. So we're actually finishing the manuscript about it to warn the audience not to worry about the changes in patients who are treated with BRAF inhibitors. This is a patient on our clinical trial who was on dabrafenib with trametinib, and that's the tumor shrinkage we saw, which 8 weeks into treatment, which is really great. And as you can see, the thyroglobulin went up, right? Not everybody's goes up, but we have seen it gone up and down. So it's quite unreliable with the dabrafenib, trametinib, or vemurafenib. And this patient had duration of response of 1.5 years. This is again neck, and that's the airway, and that's the tumor. Then why do we not start these treatments, right? They look like they're shrinking tumor so much, so why not start it as soon as possible? And the number one answer is side effects. And the side effects can be pretty bad. Most patients will have at least one side effect. High blood pressure is very common in patients who already have high blood pressure to start with. and they are on blood pressure medications, we may have to go up on the blood pressure medication doses. In patients who are not on blood pressure medications to begin with, we may need to add new blood pressure medications. So increase in blood pressure is quite universal. Fatigue is also quite universal. A lot of patients have fatigue, they just don't feel like eating, they lose weight. So definitely it impacts quality of life. They can have diarrhea, some nausea, sometimes mouth sores, sometimes peeling of skin of hands and feet or calluses. Loss of protein in the urine can be seen, so we check urine studies from time to time. Sometimes it can cause delayed conduction in the heart, so we check EKGs from time to time. So a huge list of side effects, right? This is an example of a patient with hand-foot syndrome, and it looks pretty bad, right? Not only looks, it feels also. It's painful. And there are ways to treat it. We give urea cream, moisturizer, and hold the medication. So that's why it's very important. Patients who are on lenvatinib, sorafenib, cabozantinib need very close monitoring. Initially, I see them every 2 to 3 weeks for the first 2 months to make sure this is the dose for them. I don't need to make any dose reductions because most of them need a dose reduction. And it's important and I tell patients, don't wait for my appointment. Call me if you're having side effects because you don't want to wait until it gets bad. So you want to manage those side effects early, hold the medication if need be, and so on. Then in about 2% of patients, so 2 in 100 patients, there are some life-threatening side effects that can happen too. Thankfully, they're rare, but 2 in 100 is still 2 in 100, right? So blood clots can happen, right? Blood clot in the heart or in the lung, in a stroke or a mini stroke, or bleeding. If the tumor is in the brain, there could be bleeding from there, for example. Rupture of the bowel or rupture or fistula means a connection between for example, the bladder and the intestine. So these are all bad side effects. These bad ones are rare, but they're still there. Have I seen patients who've had these? I have, because I've treated a lot of patients. I've seen the rare side effects too. And this is why we don't rush to start treatment. We wait and wait and wait until we feel, okay, I think the benefits outweigh the risks, and I think it makes sense for me to start. With dabrafenib trametinib, the side effects, lenvatinib and dabrafenib trametinib have never been compared head to head. But dabrafenib trametinib, based on our experience, side effect profile is a bit better. So if the patients have a BRAF mutation, and supposing I have an elderly patient who has a BRAF mutation, I would choose dabrafenib rather than lenvatinib because the side effect, they probably will tolerate it better. If I have a young patient who has a high tumor burden, I would start lenvatinib because if I want tumor shrinkage significantly, then lenvatinib would be it kind of depends on a lot of factors. So dabrafenib, trametinib, with or without trametinib, main side effects here are fevers and chills. So I tell my patients, if you have a fever on this medication, please don't go to the emergency room. Give me a call. Because then if you go to the emergency room, that doctor doesn't know what medication you're on, and then you get $1 million workup, right? So, and we know that this medication causes fever. So just call me, and then we hold the medication, start steroid and, Tylenol, and it gets better. Skin rash could be a side effect. The hand foot where, that peeling of skin and calluses could happen with this one too. Rarely it can cause squamous cell cancer of the skin, but it's usually early stage. You can just you just peel it off and you continue the treatment. Sometimes you can see diarrhea. Sometimes sugar levels can go up. This can also cause delayed conduction in the heart. So none of these treatments are perfect, right? Each of them has their own list of side effects. It's kind of which lesser of the two evils do you choose for your patient to make sure she has benefit, but not too many side effects too. I guess it would be wrong to call it evil too, because you do see benefit from it, compared to not doing anything. Definitely you'd see a lot of benefits, but you want to manage the side effects well, and figure out the right dose for the patient. Because if you don't do anything and the cancer grows, then that's bad too, and that's even worse. So you have to find that balance. When it's time to start, that's when we say, I think, yes, these are the side effects, but I think you're still better off starting the treatment, because clearly the benefits outweigh the risks that you have. And not everybody gets them, but I've seen a lot of patients get fevers, and that's manageable. So those are, our routine treatments, the ones that we usually do: lenvatinib, sorafenib, BRAF inhibitors, dabrafenib, trametinib, cabozantinib. These are in our armamentarium, which we use. It's very important. That's why to see an expert who's somebody who only sees thyroid cancer and sees a lot of it, because they need to know, you wouldn't, it would be hard for someone who sees two cases of thyroid cancer a year to treat the patient, right? Because there's a lot of, it's very complex. There are a lot of things that go into decision making with regards to when to start treatment, when is the right time, when do I reduce the dose, when do I hold the medication, how do I treat the side effects, when do I need to worry about a side effect. So that's why it's very important for you to be in close touch with your oncologist, and be at an academic center that sees a lot of these patients. So then you know that you are in good hands with an expert. Redifferentiation therapy, I was wondering whether I should put it or not, but I thought I'd just put it, so I just introduce it to you. But it's not something that it's very standard that we're doing. It's, it's still evolving, and we need more studies to understand it better. There are several studies that have been done, but what is it? So as I told you, right, like initially the thyroid cancer is hungry for iodine, but then over time it loses its appetite for iodine, and that's called radioactive iodine refractory, which means it no longer is responding to radioactive iodine. So what scientists have tried to do is, can I make a tumor that's not hungry for iodine treatment? So like, this is not hungry at all, it's doing its own thing, right? Can I make this now hungry for iodine? Because then radioactive iodine treatment is such a great option, and if I'm able to do that, I can save my patients from these other treatments longer. Maybe I can start those treatments later and not early. So that's the redifferentiation therapy, is what we call it, to see now now the tumor is hungry, it wants the radioactive iodine. So how are we trying to make these tumors more hungry? And there are several clinical trials that were done, but sample size means how many patients were enrolled in the study. And as you can see, they were all small numbers, right? So you can't make definitive conclusions with small numbers. Have I done redifferentiation therapy in practice? I have. It requires a multidisciplinary team. Want to make sure that endocrinologist, oncologist, nuclear medicine folks, everybody is in consensus and agrees that this makes the most sense for this particular patient. It's very based. It's an individual approach that it's not like a one size fits all. So so these medications, right, and this in patients who have a BRAF mutation, right, we use dabrafenib, vemurafenib. So these medications can make the tumor more hungry for iodine, at least based on our data that we have. That's what we are seeing. And so this was studied in a small population, in a small group of patients, 10 patients, 6 weeks, they got dabrafenib, and then they got radioactive iodine treatment. And 60% of them now took up radioactive iodine, and 20% of them had tumor shrinkage. at the 3-month mark. How does this translate to benefit is what we need to figure out, which means, can I do larger studies to see how long can I keep my patient off these lenvatinib, sorafenib, right? How can I delay the need to start those treatments? That is something that needs to be looked into more. So these were all small ones, and you can see like small 20-30% responses we are seeing. This is in RAS mutant patients, BRAF wild type patients. Again, we are, here though, this is very small number, right? 5 patients, but 80% of them had tumor shrinkage. So with selumetinib, trametinib, these are all cousins of trametinib, okay? So these, they've kind of been variable, like this one was only 7%, this one was 32%, right? And here it's at 20% at 6 months, 20% of patients still had tumor shrinkage. So something there. And then this was one of the larger studies where the combination was tested, dabrafenib, trametinib for 6 weeks. 24 patients is a big number, right, in thyroid cancer for just redifferentiation. And then what they saw is 38% of patients had tumor shrinkage at 6 months. And then they also looked at the time without any further treatment was 39 months. So that's pretty good. So this seems very encouraging. And they didn't see any bad side effects. Like, there was one concern, like, would these patients, could they transform into a more aggressive cancer? None of them transformed into anaplastic thyroid cancer. So big question is, we still need studies, but I just wanted to introduce this to you. It is used in several large centers. We do it on an a case by case basis if we think that it makes sense in a particular patient. Clinical trials, there is need for more clinical trials in this space. This clinical trial is looking at two, some tumors don't have just BRAF V600E mutation. They have other BRAF mutations. And for this, depending on the type of BRAF mutation, this is a RAF dimer driven thyroid cancer. This combination would make sense, and there's a clinical trial doing that. Encorafenib and binimetinib are basically, encorafenib is like dabrafenib, binimetinib is like trametinib, and they're looking at that combination with or without immunotherapy. And in BRAF mutated thyroid cancer, that's a study that's ongoing. There's a CAR T-cell therapy in patients with advanced thyroid cancer or anaplastic thyroid cancer. This is in a rare patient group, but RET-altered thyroid cancer, with papillary thyroid cancer, it's a very small proportion of patients with RET-PTC. With medullary thyroid cancers, we see more RET-altered, but doing selpercatinib before surgery, and then shrinking the tumor and then doing surgery. Larotrectinib is another medication that blocks this abnormality within the tumor. It's called an NTRK fusion. It is quite rare to see an NTRK fusion, but, rarely we do see it. And if we see it, that this could be a trial, because these targeted treatments tend to work well. And I only put in select trials as several others, but so some take-home points. Number one, very important, that active surveillance strategy is a very important strategy, particularly in patients who have low volume disease, not in danger locations, who have a good quality of life. We wait and watch with short interval scans. Then when it's time to begin systemic therapy, the FDA approved options we have are sorafenib, lenvatinib. We tend to use lenvatinib first line if we think that patient has, is able to tolerate it, is active and energetic, able to take the side effects of these medications. Otherwise, Otherwise, we have to dose reduce the medication if we are concerned that side effects would be a problem. Cabozantinib is in patients who've progressed on either of these. Dabrafenib plus trametinib is only for patients with BRAF V600E mutated differentiated thyroid cancer. It's effective, not as effective as lenvatinib, but it's effective with a better side effect profile. Very important to monitor for side effects closely, and redifferentiation therapy, as I said, we need further studies to understand the role better. And clinical trials are the most important, because that's the only way these medications came into being. And only if we study will we understand more about a drug and understand whether it will benefit our patients. This is our thyroid cancer program at Ohio State University. We have a large multidisciplinary team, medical oncologist, Dr. Sukritan and I, and endocrinologist, ENT, surgical oncologist, dedicated pathologist, dedicated geneticist, radiation oncologist, clinical trial office. So it's a big team, and we see a high volume of thyroid cancer patients. This is our team with our nurses and our research coordinators, our pharmacists and schedulers and oncologists, nurse practitioners and physician assistants. I'm happy to take any questions. Let me see the chat box here. I can start with reading. I see a couple of questions. So I'll start with the first question. How is there a way for someone to become more proactive about seeing if there is any presence in the lungs? My thyroglobulin has never been zero. I have had 4 surgeries, original thyroidectomy plus 3 additional for lymph node removal due to rising thyroglobulin. FNA is confirming. I want to be proactive because I don't want to wait to see if it's in the lungs and never have an answer. Is the body scan the only way, or any test recommended that could indicate? So the only way would be to get a CT check. That will tell us whether there is tumor in the lung or not. So that would be, yeah. So I would talk to your oncologist or endocrinologist to see, what are your thoughts? My thyroglobulin is still high. And maybe we should get a CT check and see, for my peace of mind, and then you'd know. In what cases do you see papillary thyroid cancer that's radioactive, iodine refractory become anaplastic? You mentioned watching and making sure you don't miss a treatment window. Is there something specific you watch for? Good question. So what proportion of papillary thyroid cancer become anaplastic is a very important question. For literature, it is a very small percentage of papillary thyroid cancer, not even in single digits. However, our experience has been that it's more than that. It's more than what's reported in literature. And the reason is that, many times patients are not biopsied, right, when the thyroid cancer is progressing. And maybe we're just missing anaplastic transformation. So the way I look at it is, if my patient had only like mild progression over the years, and suddenly in 3 months I see like dramatic progression, that warrants a biopsy. I want to know if this is still papillary or is this behaving like anaplastic thyroid cancer. And like that, I have caught anaplastic thyroid cancers, and I feel like what is reported in literature that it's a very small percentage, I think the percent, I don't have a number as to what percentage, because we'll have to look into our database to look at the stats better. But I do think it's more than what's reported in literature. If we are in the UK, is there a way we can put forward ourselves for clinical trials, or are there trials in UK? That's a good question. There would be trials in UK. The International Thyroid Oncology Group, we have representatives from all over the world, and with the experts from all over the world, with a goal to minimize barriers, right, and try to make clinical trials available to all patients anywhere they are. Problem is we run into certain roadblocks when it comes to like just bureaucracy, the logistics, certain regulatory things, because there are certain protocols that we have to follow, and then in the UK, for example, or in another site outside of the US, things can be different and the regulatory procedures are different, and they may not be agreeable to what protocol we put forth, not the experts per se, but it's more like the regulatory team. So it's a little complicated that way, and we come across roadblocks for international studies. But yes, there would be trials in the UK too. Clinicaltrials.gov would show you where the trials are open, like all over. And but yes, if the trial is international, then yes, you could enroll into that study, or if there are dedicated trials in the UK. I have NTRK3 gene fusion and I'm currently on larotrectinib. Over the year, my scans have shown complete response. I've received 2 RAI treatments before starting larotrectinib. The first was 150 millicurie, second was 200 millicurie. Would you suggest staying on larotrectinib at the highest dose I can tolerate as long as possible, or should I consider taking another RAI treatment to see if I'm more RAI avid? Very good question. It's going to be a tricky, it's going to be challenging for me to give you a definitive answer, because it's a very focused question, right? Because it's going to be because it depends on a lot of things about how your scans look, about how you've been, a lot of things, how your tolerability has been, and so on. But from what I understand here, you're still showing complete response, is what I'm gathering here, or yes, you still have, yeah. So how would you, whether you're RAI avid? So RAI avid and refractory are definitions used when there is thyroid cancer present somewhere. If you're in complete remission and there's no thyroid cancer at all, then that's not considered, you don't call it RAI avid in a way, because why are we giving radioactive iodine if there's no cancer there, right? So, so that would be kind of my take on it. If there's no cancer that we're seeing on any scan, is there a point in really taking radioactive? So the larotrectinib redifferentiation study is you're giving larotrectinib to make the tumor more hungry for iodine, but there's tumor. It's not in patients who don't have tumor at all and in complete response. So it's a little different situation. When to say it's RAI refractory? Any specific cumulative doses of RAI or the time to progression from first dose RAI? Very good question. So, truthfully, we as oncologists and the endocrinology, it's kind of the endocrinologist domain, the radioactive iodine. Patients come to me once they are radioactive iodine refractory and they need systemic therapies. But regardless, even within the experts, there's a lot of controversy as to when do you consider radioactive iodine refractory, and definitions have evolved over the years. But 600 millicurie is what is most experts say would be the cumulative dose. If you have progression within 12 months of receiving radioactive iodine treatment, then you'd say that I don't think another radioactive iodine treatment would make a much difference, because that could be considered radioactive iodine refractory disease. So to To give you a perfect answer, there's no absolute perfect definition. There are many definitions we could use. Some use increased FDG uptake. If the SUV max is more than 5, for example, on the FDG PET scan, then that could be considered RAI refractory because the tumors are unlikely to respond to RAI and so on. I have minimal lung tumors, but many bone and lung lymph nodes, right, tumors. I have been stable using dabrafenib as a first line for 3.5 years. I have no morbidity from my disease. What might my second line treatment be if my tumors begin to grow? So several options. It's great, that's wonderful that you're doing so well on dabrafenib. In our clinical trial where we compared dabrafenib versus dabrafenib with trametinib, right? In patients who were on dabrafenib, when they progressed, we saw if adding trametinib, would that make any difference? And at progression, when we added trametinib, we saw that a small proportion of patients still had tumor shrinkage with the combination. So if, for example, my patient has like very small growth of tumors, not that much, then I would say, okay, maybe I will add trametinib to the dabrafenib and see if I can get some more benefit out of it. But if it suddenly progress, if it progressed quite a bit, or there's fluid in the lung developing, for example, then I don't want to just do adding trametinib because I know the response when I add trametinib is going to be modest. Then I would switch to lenvatinib if they're a candidate for lenvatinib. Of course, clinical trials, if there's a clinical trial, that is always my first step. And I tell my patients, standard medications will always be there for us to use, right? Like you can use them anytime. If there's a clinical trial though, clinical trials come and go. There might be a promising drug that you would be able to take that you may not be able to take 2 months from now because the trial doesn't have any slots. So that's why I usually use clinical trial option first. And especially if I think that, yes, I think that this trial makes sense, it's quite promising. And then, because I can always go to a standard of care medication, but I can't get a drug that's on clinical trial outside of clinical trial.
All right, I think we're all set here. Thank you, Dr. Konda, very much.
Thank you. Thank you very much, everyone. Thank you so much for coming and inviting me. Bye.